Good afternoon. Brian Bay and I are going to talk to you about how lived experience can be integrated into the Human Research Ethics Committee review process, and some opportunities to do things perhaps a little differently. We're aiming to cover some topics that include the fact that one consumer can't represent an entire cohort. We're going to look at how decisions, research design decisions, might systematically exclude people. We're going to look at assessing risk from a lived experience perspective, and then we're going to make some practical proposals for you.
Well, good morning. Good afternoon. It's Brian Bay here. It's a privilege for me as a stroke survivor, 8.5 years post-stroke, to share my views as to the inclusion and opportunities that are created with the inclusion of lived experience in relation to the HREC review process. By way of background, I spent 4 decades amid consumer research in my corporate career, so I'm very aware of the value that we, stroke survivors, can and do bring to stroke research. My primary observation is a very simple one, that in all clinical research protocols, consumers are not generic, and it would be quite erroneous to treat them in this manner. They have specific nuances which, if overlooked or ignored by the researcher, can and do lead to a biased and inaccurate research. As a HREC reviewer, you have the responsibility and accountability to be aware of these nuances that exist within the group and the possible impact of the omission that would be created. Other areas on your checklist should be the vexed question of diversity, a quantifiable factor that, in my opinion, the landscape has yet to fully understand and harness. Also, the exclusion of various key demographic groups, rural and regional, come to mind. They are often casualties of this lack of thinking.
We're going to talk now about how decisions in research design might systematically exclude people, whether that's diversity or accessibility. Firstly, in March 2024, the CSIRO stated that almost a quarter of Australians are digitally excluded from accessing, affording, or using digital services. These are predominantly older people, those living in remote areas, people on lower incomes, and First Nation peoples. Yet even face-to-face studies often recruit online. And then unpublished ABS data from 2018 estimated that around 600,000 people who identify as having a disability rarely leave their homes. More than half of those are under 65 years of age. Being disabled is only one reason to be homebound. The question is, should the study design plan to include people who are homebound, which is what you can see in the photograph. More than 20% of people in Australia have a disability, with 90% of those being hidden disabilities. Study design, including the location of attendance, may exclude people with disabilities from participation. In the 2016 census, more than 20% of people spoke a language other than English when at home. Religious diversity is increasing, as is the number of people identifying as Aboriginal or Torres Strait Islander origin. Is the study culturally inclusive? Preferred modes of communication can impact on the decision to participate in a study, and Brian will speak further about this. There's potential for triggering content that may systematically deter participants with experience of trauma, including those whose trauma relates directly to the topic of the research or the health condition being studied. Has the study design accommodated trauma? Time commitment or the timing of contact may exclude some demographic groups. For example, those with long hours of employment or with carer responsibilities, significant time commitment to caring for their own health, or strongly preferred times of day for contact. Some studies exclude participants for simplicity of outcomes. For example, women in their fertile years, people with comorbid conditions, people aged over 60. Inclusion can sometimes increase the cost of a study, but funders can be persuaded by access and inclusion considerations. Is there evidence of attention to inclusion in the study design? If you exclude those not digitally engaged, those with disabilities, those who are culturally and linguistically diverse, and more, who's being recruited? Give consideration, will the participant profile for the study reflect the cohort affected by the findings?
Recently,
I'm going first, Brian. We're going to look at lived experience and the influence on assessment of risk. I have ME/CFS, myalgic encephalomyelitis, and most people might think that they might accept a high risk in a study only if they were dying. But someone with very poor quality of life might be prepared to do something risky for even a 10% improvement in quality of life. Someone said to me when asked about risk, if I die, at least I've taken one for the team. I was in a study designed to observe us as we were provoked into worsening capacity for effort, a 2-day cardiopulmonary exercise test. You can see the photograph. I knew it would be bad for me, but I wanted to help move knowledge forward. The outcome for me was 6 months of massively worsened disability. Within an hour of the second day on the exercise bike, I could not stand or speak. I fell into a taxi, unable to access my memory. I had no idea where my home was, if I lived alone or with others in a house or a flat. I ask you to imagine how frightening that was. It took me 6 months to recover my usual level of disability. A recent study looked at long-term effects of the 2-day CPAT in ME/CFS and found that one participant had not recovered function after 12 months. As a member of an HREC, how much risk do you consider to be reasonable? And how can you know how much risk participants in a particular cohort would consider reasonable? Over to you, Brian.
Thank you. Recently, I was involved in the recruitment of stroke survivors in the UK who had sustained aphasia as a result of their stroke to take part in a trial. There was a reluctance on the part of the survivors to participate in focus groups. They found the considerable embarrassment. They endured considerable embarrassment by sitting in the group and talking as is the normal practice. The preferred strategy for this research project was one-on-one interviews. This was also another challenge I encountered when we were recruiting stroke survivors who had sustained PSE or post-stroke emotionalism as a result of their stroke. Now, I'm a consumer. I suffer from post-stroke emotionalism, which is a neuro condition. 15% of stroke survivors suffer from it. And one end of the spectrum, it's uncontrolled giggling and laughing, to the other end of the spectrum, which is crying, sobbing and weeping, and it can come on at any time. So therefore, most people we were trying to recruit, 70% of them prefer to have a face-to-face interview rather than sit in the joint focus group. I can only assume that these characteristics are common to all areas of clinical research. So I'll remind you again of your responsibilities as reviewers. It is indeed a broad church. One size does not fit all. Penelope?
Yes, getting practical. We're inviting you as an HREC to ask researchers for more information or evidence of community support or concerns before you simply say yes or no. One area we're quite concerned about is interrogating letters of support. We're interested in who has been approached for support letters, and have there been any refusals to provide such letters? And the letters themselves, do they address the objectives and the aim of the study? Do they address the risk versus benefit appetite for that population? Do the letters address who is excluded and how that might influence or bias the results? Do the letters indicate who the author consulted to inform that letter of support? Are there any declarations of conflict of interest or indications of an intent to actively support the research? Have there been any references provided to support the advice? For example, where there is a perceived high level of risk of harm, are there academic papers to support why the author of the letter might consider that to be an issue? Basically, we're asking you to identify and challenge assumptions on which researcher or HREC decisions are based.
As HREC reviewers, you must ensure that researchers in their protocols focus on the right people in the right environment and ask the right questions. If you have not lived with a condition, its challenges and risks, then how can you, the HREC, decide what matters to someone living with that condition, or what they might be willing or not to risk or to do? How will you find out? Thank you. I now open the floor for questions.
Thank you.